So thanks for coming to Plastic Surgery 90210, and today I have the honor of introducing Dr. Tim Neavin, a board-certified plastic surgeon here in Beverly Hills, longtime friend, good colleague, and really an expert in plastic surgery.
Thanks, Dr. Katzen. It's great to be here.
Thanks for coming.
Thank you.
So I've been in practice since year 2000, so about 23 years now. And Dr. Neavin?
I started my practice in 2008 after finishing a fellowship with Richard Ellenbogen here. And I think I met you, sometime around that period.
Yeah, Dr. Ellenbogen, another pioneer of plastic surgery, especially cosmetic plastic surgery and specialty in multitude of areas. And I remember seeing you in the operating room there doing your fellowship and golden hands there. So
it's been a long time, right?
Yeah, so it continues. Yeah, so it's great.
Thank you.
Sure.
And Dr. Neavin, what is your specialty?
Well, my specialty is probably fat transfer. I enjoy doing everything, but if I had to choose one passion, it's fat transfer, and I put fat wherever I can.
Okay.
Fat, I put in the face, I put in the breast, even in the penis, the labia. So that's a real passion of mine, is using fat to remodel tissue.
So I've been stalking you on Instagram, and you have a large following there and some amazing results. We can distribute fat anywhere, but you seem to get the best results that I've seen.
Well, that's awfully flattering. I don't know if I have the best results, but thank you. I've just been doing it for a long time. I did my fellowship in 2007 for a year. I did it under Richard Ellenbogen again at Pioneer. So I spent a year just doing almost nothing but that, really. And so I developed a really, passion for it. I just think it's a really powerful way to rejuvenate the face. And when I give lectures on this, I show a picture of a baby's face, and I say, how we describe this? It's a ball of fat.
Right.
So that's our starting point, right?
Right. All chubby and cute.
Yes, it's a ball of fat. And then I show a photo of a woman or a man who's 85 or 90. And how do they look? They're gaunt, they're sunken in. I said, we're all along that spectrum somewhere.
Right.
If you want to get closer to the baby, you got to put fat in. And so that's how I look at it. And that's how I when I tackle, patients, I look at their face and their architecture. I try to explain it to them, and because a lot of people don't want a fat face, but they sort of understand it when you put it in those terms.
Right, absolutely. So the chubby face makes you look younger, and we get a lot of that with weight loss community. They'll be X amount of weight, and they'll lose 100, 200 pounds, and their face will lose all the fat in it, and rapidly over 8 months, they will have aged just because they lose all the fat in the face.
Yeah, it's really the hallmark of youth is fat in the right areas, right?
Sure.
I think to describe top-heavy faces. The fat in the temples and the forehead, upper cheeks, and or trapezoidal in men, heart-shaped in women. But as we age, we get the peanut head, right? Okay. Sunken in temples. I'm in that phase right now, I think.
Peanut? No.
I have some sculpture in my temples and fat, for the record.
Okay.
But then we turn from the peanut head to the upside-down heart, or the egg, right? Upside-down egg. So restoring youth and fat, you got to get balance, right? So you want to go top-heavy on most of these patients.
Gotcha.
Otherwise, you can make them look, have, I guess you could say, unbalanced fat faces rather than youthful faces.
Gotcha.
That's how I see it anyway.
Yeah.
So buccal fat's a hot topic, right?
Absolutely. And everyone wants it.
Yeah. So that's interesting because I like putting fat in the face.
Right.
And so it seems almost heresy, is that the right word? To take fat out of the buccal space. But there are reasons to do it. And the way I explain it to patients, why I see it, is you look at the shape of the face, the architecture, right?
Okay.
So in people that have bottom-heavy faces, you can often remove a little bit, not a lot, maybe 30% max in the buccal space to try to restore that bottom-heavy face into more of a heart-shaped face.
Okay.
And the right person, it can really reshape them and make them look like they lost weight. I sometimes coin it the quickest way. It's like a weight reduction surgery without the weight reduction, because they can do this procedure and then it's shockingly 6 weeks later, 7 weeks later, swelling goes down. Like, you lose weight? We never get the credit, right?
Right.
But they look amazing. But in the wrong person, you can really make them look gaunt and older.
Too much.
Absolutely.
Yeah.
So you co-authored a study on positive influences of plastic surgery on one's sex life. Could you provide more insight about the research that went into that?
Why does everyone know that?
So this is great because I was a second year resident, and for whatever reason, I was on very unfavorable terms with the lead author up to this point, right?
Ooh, okay.
So, we just, we had a lot of friction.
Sure.
And now we're like best friends, by the way.
Cool.
So I heard he was trying to do a study looking at the results of plastic surgery and how it influences one's sex life. Okay. And so I want to get on his good graces and say, look, I'm fascinated by both, all the above, right? So let me help you out. And he was hesitant, and he said, okay, I'll give you the task. So I developed a questionnaire. Okay. And I was a resident. I was busy, so usually like trying to tackle a lot of things at once. So I said, where can I get, questions about sex? So I went to like Playboy or Penthouse or something, and I listed them all, and I said to him, and he goes, this is ridiculous. This is obscene. What were you thinking? And I really didn't read the questions. And so he almost kicked me out of the program, honestly. He's like, are you making a joke out of what we're trying to do here? No. And I'm like, oh my, so I read the questions. I'm like, oh my God, these are horrible. This is like really too lewd, And so I went back to the drawing board, and I said, okay, let me think of this more seriously and actually do the research. And I guess I could say I watered it down a little bit, make it more appropriate for a journal, sent it to him. He said, this is fabulous. So we went with it. We sent out letters to hundreds of his patients in the last 10, 15, 20 years, whatever. Wow. He's a senior guy, looking at, questions were like, do you think you have sex more frequently or less frequently? Do you feel more positive about your body? Lots of, every question imaginable that was tasteful. Right. Unlike the other questions I just grabbed out of a magazine because I was really busy. And we sent it out and we published it, and it became the lead article in the Aesthetic Journal. Wow. And that was like my second year in training. This is so cool. Yeah. And he gets invited to a talk show. I think it's Today Show, yeah. Excellent. So he's on the Today Show, and I go, if you're on the Today Show, you better plug me. I want to be watching. Excellent. So nationally, he plugged me, said, thanks to Dr. Neavin, we got these results. Awesome. And I was like, wow, this is so cool. So you were on the Today Show? I should be the lead author. I should be the lead author, though. By the way, for the record, I should be. But I'm not. But it's okay. Dr. Guy Stoffman is a lead author. He's a fantastic friend and surgeon, and that we put that together. And it was really, very exciting for me. So now you need to do a follow-up, and you'll be the lead author? Yeah, I should actually. Yeah, it'd be a great idea. Easy enough to do. Absolutely. Yeah. Very cool. All right, great. And so let's talk about how you do fat transfer into the labia and the penis. How did you get into that, and how does that relate to what you were just talking about with that book about sex life? Okay, so I transfer fat into the labia and penis. I started doing the labia first, but then I transitioned to start doing more of the penis fat transfer. And a lot of it was born out of the fact that I do a lot of male plastic surgery. Because I was doing hair transplants since 2013 or 14. I had one of the first neografts in the city. Cool. And became busy doing that. And then I just transitioned to that into gynecomastia, and then what other procedures can you offer? And men started asking about it. So I had a close friend and mentor named Keith Jeffers in Atlanta. He's a fellow Pitt alumni. I think he graduated 6 or 7 years ahead of me. And he learned from a urologist who is retired now about this procedure. So I visited him. Cool. To hang out, we're close friends, and he did a procedure when I was there, and I was like, this is really magnificent, and it's easy, and it's safe. Right. So I started doing it, and one thing led to another, and I started, getting more and more patients, and next thing you know, the Penis King in Los Angeles. I mean, I know, what I'm saying. Yeah. So I enjoy doing it, because the patient population is fantastic, and it's a very safe procedure, and the men tend to love it. So with the labia, it's, again, you've done it too. It's very simple and easy, and it really rejuvenates that area. Yeah. Because people don't think of like deflation, right? That's an issue. The labia majora in that area as a sign of aging, but just like the face, it deflates, loses like a beach ball, like right? You got to reinflate it. Yeah. And it's easy and safe, and it really rejuvenates that area as well. Yeah. It's a great procedure. Yeah, it's fantastic. Yeah. I have some patients addicted to it. Sure. I've had some patients that have 3 or 4 sessions. Wow. And one patient was so large, he got frisked at the TSA flying back to Chicago. It's a true story. And they called you? No, okay. We did I think 3 or 4 on him. Wow. And he was enormous. Okay. And so I gave him almost like in a joking fashion, I gave him a doctor's note because I know he's flying, right? Saying it. Oh my gosh. And he called me before we boarded the plane. They took me aside, and they stripped me down, and they didn't know what I was packing. And I was like, wow, that's an amazing story. Can you write a review?
10,000 people that went through LAX.
Can you write a review? Like, that's
Excellent.
beautiful.
Yeah.
And so, yeah, that's an unusual, I guess, consequence of fat transfers getting frisked to the TSA.
So your results are certified by TSA.
Yeah, I think so. Yeah, exactly.
Yes.
It's contraband.
Yeah, excellent. And what I mean, I know there are a lot of variables that go into how much fat can be placed into the penis. What's the most fat you've ever placed?
Probably 100 cc's.
100 cc's.
And I think even
at one time.
Yeah, yes, but asterisk, right? So this is a guy who's had multiple before. So as you know, every time you do a fat transfer, you're building the surface area for a subsequent fat transfer,
Sure.
So the first session, you're not going to, you need a large surface area to put 100 cc's in.
Yeah, sure.
I'd say the average probably 25 to 40, 45 maybe in one session.
cc's.
But it all depends on the surface. Like the larger the penis is, the more fat you can put in.
Okay.
And after 3 or 4 sessions, you're building that surface area. But the most is 100.
Got it.
Yeah.
That's impressive. Very impressive.
Great. And let's talk about how you think body positivity is connected to plastic surgery.
So when it comes to body positivity and plastic surgery, there's a direct correlation, right? I think, and this is interesting. Like when we talk about plastic surgery, the end result is what? It's not like necessarily the physical result. It's how do they feel about it, right?
Exactly.
It's so different than like taking a gallbladder out.
Yeah, exactly.
Or an appendix, and it's a pretty concrete, easy result. Gallbladder's out, no longer sick.
Exactly.
Here you can, you're treating this as much as you are everything else, and I think that that's because that's the ultimate result or a measure rather for success. It puts a lot of pressure on us to deliver what they want, but the upside is, of course, it's you hit out of the ballpark and they're thrilled and it's life-changing. I mean, our study proved that it's life-changing for these people.
Yeah.
I guess the most frustrating result is one where that you could not have done a better job.
Yeah.
And every patient has their anatomical limitations, right?
Absolutely.
So we kind of know what we can a home run is.
Right.
And if they don't see that home run, they see a single or double or even a strikeout. It's like, what do you do now, right?
Yeah, exactly.
Which is why expectations are so vital.
Exactly.
So Dr. Katzen does a lot of, reconstruction after massive weight loss surgeries. You know how insurance companies oftentimes say that's just cosmetic, but it's not always cosmetic. I would like to hear your opinion on that.
So when it comes to massive weight loss and the surgeries necessary to restore their appearance, I look at it as restoring normal function in a way, because normal appearance is a function of society, and that's how I would argue it.
Right.
But you're right. I don't think insurance covers a lot of it unless there's a physical
functional
issue,
limitation. Yeah.
right? But I think and correct me if I'm wrong, I would argue that looking normal is a function of society. So it is a functional surgery, no matter how you look at it.
True.
And you do more than anybody, right? So you see the results. You see how these patients now feel more comfortable in their own clothes, literally and figuratively, right?
Yep.
And how they feel more, accepted in society because they look more normal.
Sure.
Right?
Sure.
So when it comes to overfilling fat, it's a good topic to discuss because I think I'm trying to think. There's a study that I saw that showed that the maximum or optimal amount of fat in the malar area is about 7 cc's, give or take, because any more than that, what happens is you get apoptosis, right? If you overcrowd the space, you have paradoxically more fat that dies.
Sure.
So
that means you get an area and you put some fat in. But if you put more fat, it's like putting too many people in a room. They start to squish each other, smother each other, and then the fat dies. So by putting more fat in, you kill the fat that you already put in there. So you can put too much fat in.
Yeah, right. If you look at 3 cc's versus 7 cc's in any given area, you might end up with a higher retention rate and more volume at the end of the day with putting 3 cc's than 7 cc's. Mm-hmm. Because the 7 cc's may kill 6 cc's.
Yep, absolutely.
It's so strange. It's a lot of just experience, looking at the face and the age of the patient and the fat itself, where you kind of say, okay, I think I can get away with this much here and there. I will say this is really hard. There's certain areas almost impossible to overcorrect. It's almost impossible to overcorrect the temples, almost impossible to overcorrect the lips, Almost impossible to overcorrect the periauricular area. The areas you got to be, and the buccal space for that matter, the areas you got to be concerned about or overcorrecting is the malar fat pad.
So you can make this too big.
You could.
Okay.
That's the one, one area if you're going to screw it up by putting too much fat in, that's the area it's going to be.
Gotcha. So it sounds like you would rather do maybe several procedures, touch-ups, if you will, than just one big session and just hope 99% of it survives.
Yeah, when it comes to the number of sessions for optimal results, almost everyone will see a really nice natural improvement after one result.
Yeah.
And then you wait 6 months or so,
6 months, okay.
And then if the weight's stable, if you're going to go back, you're going to get a better retention rate because a higher surface area, like we talked about, right?
Yeah.
More surface area, you'll get a better retention rate. But you can hit a ballpark with one session, if you put the fat in the right proportions in the right areas. You got to put if you're going to put the cheeks, you got to put in the temples, right?
Okay.
And by the way, you got to put in the periauricular space.
Makes sense.
And probably maybe in the buccal space, just to balance it out.
Yeah.
As long as you keep the proportions right, you should be able to, get a really nice natural result with reasonably good retention. And just like the lip, as you know, right? But when you fill the lip, you got to put in the upper and bottom lip, and
balance it.
Same with the face. You can't just say, I'm going to put fat right here and call it a day.
Sure.
Well, there are exceptions to every rule,
right.
But for the most part,
balance.
Mm-hmm. And hearing you guys talk about this and the balance really shows the artistry that goes into plastic surgery. Let's talk about that. Let's talk about how you feel like you're truly sculpting, not just performing any type of surgery while you're doing this.
Yeah, I think plastic surgery is a form of remodeling or sculpting in many ways.
Absolutely.
And that's the fun part about it. You can express your artistic ability. You don't want to be a Picasso, maybe a Leonardo da Vinci or something, but you are really, because when you're looking at the face and the anatomy, you're a diagnostician.
Mm-hmm. Yeah, trying to figure out what the problem is.
Yeah. And when it comes to fat transfer, I look at shadows of the face. And that is usually like the blueprint of where you need to add volume because shadows develop, concavities. And if you took a photo of a baby's face versus a 9-year-old's face, you'd see the difference in shadows. Sure. And when you fill shadows, you kind of restore the fat where it wants to be.
Sure. If you think about it, babies don't have too many shadows. They're all just round, chubby, and cherubic.
Exactly.
And let's take a blast to the past and talk about why you went into plastic surgery.
So I went into plastic surgery. I went to medical school to be a psychiatrist. Really? And that was my passion. I was a psych major. Okay. And I was fascinated by Freud and psychoanalytic theory and all that stuff. And I pictured myself, with the pipe on the couch. And then I got the med school. This is not exactly what I thought it would be, right? This is a little different. Yeah. I liked it, but I was like, I can't do this for the rest of my life. It's not my passion. Then what am I going to do? And then I did a surgery rotation, and I enjoyed it. The hands-on feeling and the appeal of cutting things and sewing them up. It was very satisfying. Sure. But you take out a gallbladder and you close it up and you can't see my work. Exactly. It's like what's the point, right? Exactly. And then I said, wait, there's got to be something that really fits my personality. Sure. Mm-hmm. So I just cold called. Actually, I didn't even cold call. I just walked into a plastic surgeon's office who was at Jefferson Medical College in Philadelphia. Okay. It was Foxmore and Coauthored at the time, 3 of them. Walked in and said, I want to be a plastic surgeon. And who are you, right? And he goes, make an appointment. What's going on here? Exactly. And so I made an appointment the right way. And I sat down with them. I said, can you guys be my mentors? I want to do this. And he said, sure, follow us around. And that's really cool. My free time, I would scrub in with them and then do a rotation with them and did some studies with them. And I was like, wow, it fit my personality, And you probably agree, every subspecialty of medicine has its own personality.
Absolutely.
And there are stereotypes, jocks are the what?
Orthopedic surgeons.
The nerds are the... All right, so, and the cool artistic people are...
Plastic surgeons, of course.
And I fit in.
The rock stars.
Yeah, the rock stars. Yeah, exactly. Yeah.
Cool.
You're the rock star.
Wait, who are the nerds? What do they do?
The neurosurgeons and neurologists and the nerdy ones.
I should have went into that.
I still got water in my cup.
Oh well, I'm not afraid of water. Cool. And so you went into that, and let's talk more about the artist side of you. So we actually know that you do music, you're into cars, you collect video game consoles. Let's talk all about that.
Yeah, so outside of plastic surgery, I have interests, and I think that I think it's important to have outside interests because this can consume your life. And for some people, I think it does, and maybe that's what they want. For me, I love what I do, but there are other things I want to explore in life. So when I came out here in 2008, the first thing I did is I enrolled in screenwriting classes at UCLA, and I did that for 3 years.
Really cool.
So I always wanted to write a screenplay. And by the way, if you think our job is hard, try writing a good movie. It's hard. I mean, it's hard, and it's a true science. Like you have 3-act structures, and every page has to keep you guessing, and there can't be any wasted space. There can't be any wasted scenes. Everything's got to move the story forward. There's setups and payoffs. And at the end of the day, you need to really extract emotion out of someone in 2 hours. Like, isn't it amazing when you think about it? You go to a movie, right?
Right.
And you're there for just 2 hours, and you leave, and you can think about this movie for, like, days.
Sure.
In 2 hours, how do you generate that emotion with a pen and paper? And
lots of zombies.
It's crazy, right? So I did that, and then so I've written some screenplays for fun.
Very cool.
If they get made, cool. I'm looking for producers. And
here's your guy.
Yeah, right. And then I started painting during the pandemic. And then I started making music a couple of years ago, taking piano lessons. I do collect vintage arcade games.
And your Spotify handle is?
It's 10blade, TENBLADE. 10blade.
Sign up.
Exactly. So yeah, 10blade's a scalpel.
Exactly.
And then I collected vintage arcade. I still collect vintage arcade games.
How many do you have?
15 or so.
You have a lot of quarters at home.
Well, what I do is I convert them to tokens.
Oh, okay.
Because you can do free play, but it's not the same experience as putting something in the slot, right?
Very cool.
So I have these tokens, just like throw them in.
Very cool.
Great. And Dr. Neavin, do you have any questions for Dr. Katzen?
Yeah, so Dr. Katzen, you are, of course, world-renowned in body surgery and plastic surgery in general. What is your approach to, like, a weight loss patient, timing-wise? And the most challenging part, I think, is how tight can you get them safely? That is really what it comes down to.
Really good questions. So the timing is their weight has to be stable. We get a lot of patients even before their gastric bypass. Dr. Katzen, I want plastic surgery. I'm like, well, you got to lose the weight first. So lose the weight. Typically now the surgery to do is the vertical gastric sleeve. Before it was the lap band, then it was the Roux-en-Y. But anyway, you lose the weight, and then after about 8 months, whatever procedure you've had, your weight sort of plateaus, whatever you're doing. Diet, exercise, whatever you do, your body sort of says after about 8 months, okay, this is what we're going to weigh. Ideally, you're at your ideal body weight, but often you're not. You're either above it or below it, but it is what it is. So after about those 8 months, and your weight has to be stable for about 3 months, then you're good to go. And typically, I start out on the tummy, and then we can do the hips and the backside, the body lift first. And then we branch out number 2, stage 2. Sometimes we combine it with the body lift, will be the thighs. And then third stage will be the upper body, the chest and the arms and or the back. And sometimes stage 4, the face. And as far as tightness goes, with weight loss patients, they're different. Their skin's been stretched out, 600, 700 pounds, and then they lose the weight. It's sort of like an old balloon that's been overstretched.
Right.
So on weight loss patients, you've got to pull and tug as tight as you can to get it approximated. So unlike maybe standard tummy tuck, maybe the tension level's maybe a 3 out of 10. With the weight loss patients, it's like an 11 out of 10. You got to just pull it super tight. You do it in layers. You do the tightness in the fascial layer, and then the scarpus fascia, and then as you get to the skin, there's less and less tension, but still there's a lot of tension. And even on some tummy tucks, maybe I would say about 5-7%, we get them super tight at surgery, and they come back 6 months later and they have redundancy, and you got to do them again. And you're like, I swear that was tight.
Yeah.
And it's just the elasticity of the skin lets up again, and you got to touch them off again.
So another question I have for you, and I find is the most challenging part of these kinds of surgeries, like, what is your marker on the table? Like, when you're pulling, what is your marker where experience is probably the easy answer. But is there anything else? Do you look at the skin? Does it blanch when it's too tight?
Yeah. No, so, we make our markings before the surgery, and that's all nice for our pictures and everything. But when everything's on the table, there's one line we use. So when we're doing like a body lift, there'll be the lines we want to resect, the line on the top and the line on the bottom. And one line is a fixed surgery. Okay, so we make the incision there, and the other line is sort of a floating line. So that's the amount of tension we can either take more or less from. So on the front part, on the tummy tuck, we put the incision down low, we dissect, and then we pull everything down. But the best way I've found to measure the tension with los manos, with your hands. Right. And you use your hands, I use these towel clamps, and you basically just pull the tissue together, and you can feel the amount of tension in there. And just by experience, you can sort of tell, okay, this is too tight, slack off and take a little bit less. Oh, this is too loose, we can take a little bit more. And we put out usually 7 towel clamps each side. So we go by about 2 centimeter increments to sort of gauge the tension throughout the incision. Yeah, it's a tensometer.
That's why I have to see some of the experience, because that is the hardest part.
Yeah, absolutely.
Is getting the tension as good as you can get it for the best result. Yeah. That is really challenging.
Yeah. And sometimes you can go 2 centimeters at a time, reapproximate, put a couple stitches in, another 2 centimeters, but that would take forever. So we usually make one bigger incision and just complete it, usually in 4 incisions, one on the top of the butt, one on the top of the other butt, and the other section, the tummy, 2 sides.
And I've seen you operate. You're very methodical. Like I could tell, you've got it down to a science. There's no dilly-dallying. You know exactly what you're doing, and it's really an art form the way you do it.
Thank you.
You make it look easy, and I know it's not easy, because when I do these cases sometimes, I'm like, wish Katzen was here. And I've called you before. Actually.
Absolutely, yeah. So anytime, I'm more than willing to help. And they're big surgeries, but they're very rewarding surgeries. With my patients, there's no way you cannot tell the difference between the before and the after pictures. It's obvious. Anybody can see that.
And scar widening. What do you tell patients about that?
I tell the patients, look, it's always a trade-off. Do you want to get rid of the extra skin and the fat? Yeah. Well, there's going to be a trade-off. You're going to have a scar. There's no way around it. Or do you want to keep the skin and have no scar? Most of my patients, get rid of the skin, get rid of the fat. I don't mind the scar. And I always tell them, scars can always be modified. We're plastic surgeons. We sort of never give up. We can always remodel the scars. It's rare in my weight loss patients that we get keloids, period. It's pretty rare.
Really? Okay.
It's super rare. In 25 years, basically, I can only think of 2 patients that had keloids.
That's remarkable.
One patient that came in with massive keloids, but her tummy was below her knees. And I'm like, look, do you want to get rid of your tummy and have a keloid, or do you want to live with your tummy? She's like, get rid of my tummy. So we got rid of the tummy, but she did develop a keloid. The other was in a Caucasian woman on her arms. Don't know why, but those are the only 2 cases. So keloids are very, very rare. But in terms of scar remodeling, I tell them, look, we got the laser, we got steroid injections, but it's very rare that we need to revise scars.
Interesting.
Yeah.
Yeah,
due to the tension that we put in this incision and also the sutures we use.
And what do you think is the most challenging area when it comes to reconstructing the body in a massive weight loss patient?
Yeah, I think probably the most challenging 2 areas probably are the breast and the thighs. Okay, thighs are a difficult surgery because you're dealing with the lymphatics. Lymphatics are sort of these invisible, they're kind of hard to see channels for the body to drain lymph fluid, which is a circulatory system in addition to your blood, but it's hard to reapproximate those and get those together, and sometimes they leak and lead to wound opening. Okay.
Right.
The other hard problem is the breast. Now, with weight gain, weight loss, the breast will sag. Sometimes the inframammary fold, where the breast meets the chest wall, I've seen it. It's actually below their rib cage.
Right.
So you've got breasts that start down to there. You're doing a tummy tuck. You're pulling it even further, and then the breasts are almost touching the belt line. So you're like, what am I going to do now? Then the tissue is shot. So a lot of the time you got to use this mesh internally, and then you're putting an implant on top of that. So you got all these vectors going on. So I think breasts are...
Absolutely. And then you add an implant. And exactly. Oh my God, right?
More and more weight.
Expanding the tissue and reducing the tissue.
Exactly.
It's a really tough...
Yeah.
That's
what's challenging.
Experience comes in very handy in those cases for sure.
Yeah.
I could probably ask you questions all day, actually.
Well, let's just end with your message to the world.
Oh my goodness, my message to the world. Be a good person. That's about it.
That's a good one. Yeah, that's a good one. Do what you love to do.
And do what you love to do, yeah. Find a passion and find multiple passions, actually. I think, there's so much in life to explore,
Absolutely.
Don't let your job consume you. That's my advice. I love what I do, but, part of life is doing other things.
Yeah.
And it's good to have different interests. And that's about it, yeah.
Yeah, I feel sorry for people that say, "Oh, I'm bored," because there's so much out there. Oh my gosh, so much to do.
Yeah, I heard this one saying that if you're bored, that means you don't have enough goals in life.
That's
You
true.
know, because there's always something to do.
Absolutely.
I think.
Just go on the internet. I mean, there's so many things to do.
Yeah.
Thank you very much, Dr. Neavin, for joining us. It's an honor to have you. And
Honor is mine, Dr. Casson. You're an amazing person, an
man.
amazing surgeon. And
Thanks for coming.
love watching you operate. And hope I can sneak in the operating room, watch you do more stuff, more your magic.
And I hope I can join you on some surgeries.
Thank you.
So thanks for joining us. Plastic Surgery 90210.
Thanks.
Yay.